Hi guys, this is Amrit and I would like to welcome you to OsProEd. This video is for educational purposes only and please never practice medical skills without the proper credentials. The topic in this video is acute renal impairment, which is a syndrome characterized by a rapid, usually defined as within 48 hours, fall in the glomerular filtration rate with a corresponding rise in the serum creatinine level. That results in like an increase in the metabolic waste products that are normally excreted by the kidney. There is a criteria called RIFLE, R-I-F-L-E, that we use in acute renal impairment, which helps to assist in defining the stage of acute renal impairment. So RIFLE stands for R-I-F-L-E. So R is risk, so acute renal risk. I is injury, so acute renal injury or acute kidney injury, like AKI. F is failure, so acute renal failure, ARF. L is loss, so acute kidney loss. E is end-stage kidney disease, so ESKD, end-stage kidney disease. Okay, so you can Google the RIFLE classification of acute renal impairment, and the different stages are risk, injury, failure, loss, and end-stage kidney disease. And it also talks about like the serum creatinine levels as well as the GFR and also the urine output. So whenever you get time, please go through the RIFLE criteria and you'll get a good understanding of what I'm talking about. Okay. So it's important to find like the causes of acute renal failure. The causes of acute renal impairment can be considered in terms of like the source of the renal pathology, such as like, is it pre-renal, is it renal, or is it post-renal? So pre-renal is usually 70% of the cases, and renal is about 10% of the cases, whereas post-renal is about 20% of the cases. So I'm going to break down each one of them and we'll look at what some of the causes. So under pre-renal, this is due to usually reduced systemic blood flow with secondary reduction in renal perfusion. So we can think about hypovolemia, and hypovolemia can be of any cause. So hypovolemia is one of the commonest pre-renal causes. Another one is reduced cardiac output. So again, this can be from any cause. And edematous states with reduced intravascular volume. So things like congestive cardiac failure, hepatic cirrhosis, or nephrotic syndrome. Okay, so then moving on, we've got the renal causes. So this is due to intrinsic renal disease. Under the glomerular, we've got the primary glomerulonephritis and secondary glomerulonephritis. Then we've got the tubular ATNs. It could be secondary to ischemia from any cause, including like as an end result of reduced blood flow, or it could be like drugs and toxins. For example, somebody who had like radiographic IV contrast or renotoxic antibiotics such as like aminoglycosides or toxins like myoglobins. And then under renal, we've got also interstitial disease. So interstitial nephritis, most commonly this will be drug related, or infections like pyelonephritis or severe sepsis in general. We've also got metabolic disease like uric acid, multiple myeloma, hypercalcemia, so things like that. And then finally, we've got intrinsic renal vascular disease that includes like large vessels, so renal artery obstruction, so such as like renal artery stenosis or renal artery thrombosis or embolism or dissection, or hepatorenal syndrome. There's like a reduced renal blood flow in this syndrome, or renal vein thrombosis. There can also be small vessel disease, so microvascular disease like hypertension or diabetes or connective tissue disease, including vasculitis, DIC or TTP, or, drugs that affect renal autoregulation and reduced glomerular perfusion. So drugs like ACE inhibitors or sartans or NSAIDs or PG inhibitors. Okay, and then finally, we've got the post renal causes. This is due to like renal tract obstructive causes. So it could be like upper, so upper meaning like kidneys and or ureters, like a retroperitoneal fibrosis, or abdominal or pelvic inflammatory or infective conditions. Um, it could be abdominal or pelvic malignancies involving like obstruction of the ureters or obstruction due to like stones. We also think about like ureteric obstruction in the presence of a single kidney, or when the unobstructed kidney is not functional. It could also be like malignancies like bowel cancer or cervical cancer or lymphomas or ovarian cancers or metastatic cancers in general. It could also be like a post-renal cause from the lower urinary tract. So could be like the prostate, like prostatomegaly, benign or malignant, prostate cancers, bladder cancers, urethral strictures, or a blocked catheter. Yeah, so all of this, can cause issues. So speaking about complications, so complications of acute renal failure, well, the most immediate threats to life in acute renal impairment will include number one, hyperkalemia. Number two, pulmonary edema. Number three, acidosis. Number four, complications of the underlying cause of the acute kidney impairment. For example, like sepsis or vasculitis. And number five, in acute and chronic cases, uremic coma or seizures or cardiac tamponade may also be an immediate threat to life. When it comes to clinical assessment, it's important to make sure like we can get a history of volume loss, so whether the patient has like a poor fluid intake. So it's common to see that in especially like the elderly, or if there's like GIT losses. In history also, we want to find out whether there's any history of urinary symptoms, in particular like macroscopic hematuria. Acute renal failure is that which is associated with macroscopic hematuria, and it suggests rapidly progressive glomerulonephritis and is a medical emergency. Then urine output is also important, like is the patient making urine? So anuria suggests like total renal tract obstruction or vascular obstruction, or glomerulonephritis or severe sepsis. So all of these are medical emergencies. Then we also think about like medications. Is the patient like on diuretic agents or nephrotoxic drugs like NSAIDs or ACE inhibitors or sartans, or was there like a recent IV contrast that was used? And then moving on, we want to know the past history. So in particular, like is the patient having a past medical history of diabetes or hypertension? Do they have like any connective tissue disease or autoimmune disease? Do they have any known previously documented renal impairment or any anatomical renal tract abnormalities? Then we also think about like abdominal or pelvic malignant disease. So think of possible like urinary tract obstructions or tumor lysis syndrome, especially in those patients on chemotherapy. So think about all of that. Important points on examination. So assess for any immediately serious symptoms such as altered consciousness state. So this can happen from uremia. Look for any hypotension from hypovolemia. The possibility of cardiac tamponade also needs to be kept in mind. If the patient has like chronic renal failure, then look at the breathing. Is there any dyspnea, especially like from pulmonary edema? Then we try to assess the volume status. Is there a reduced intravascular volume? So we look for tachycardia, hypotension, poor peripheral perfusion, expanded extravascular volume, so ascites, edema, pleural effusion, elevated JVP, crackles in the lungs. So all these, are helpful in assessing the volume status. Then we check for signs of possible chronic renal failure. So this would be like peripheral neuropathies, anemia, or uremic skin changes. And then look for the bladder, so check for a palpable bladder. In hospitals we've got bladder scanners, so we frequently use them, so you can pick up the bladder scanner and use it to document the bladder volume. And finally, IDC to establish the rate of urine output. So, acute versus chronic renal failure. So, it may be unclear on occasions whether it's the renal failure or like, is it acute, is it chronic, or is it acute on chronic? So, if there is doubt, it's safer to assume that the patient has acute renal failure rather than chronic until proven otherwise. The following features suggest a chronic picture. So, for example, small kidneys on abdominal X-ray or ultrasound, previously abnormal renal function results, uremic signs. So, uremic signs are things like skin pigmentation, peripheral neuropathy, renal bone disease, or anemia. So, in acute renal impairment, the investigations that we will do will examine the patient and assess their fluid status alongside a bladder scan for any evidence of retention before reviewing the drug chart for any nephrotoxins that could be causing or confounding the condition. We can, then think about blood tests. So these would be like your FBE, normochromic, normocytic anemia may be seen, thrombocytopenia may be seen. So if it's like a TTP or a HUS, we also look at blood film examination. You may find microangiopathic blood films, again suggestive of TTP or HUS. We want to do an ESR or CRP, suggestive of an inflammatory or autoimmune condition. However, these tests are non-specific in this condition. Then we want to look at the kidney function and glucose. So make sure you also include an urgent potassium level to rule out any life-threatening hyperkalemia. In general terms, the serum creatinine is the best guide to the glomerular filtration rate. And then we think about calcium and phosphate, VBGs to assess the degree of acidosis if the patient is unwell. Other not so important in ED setting may, according to the index of clinical suspicion, we can include uric acid levels, protein electrophoresis, if multiple myeloma is suspected. This is recommended for any patient over the age of 50 years with unexplained renal failure. We can think about serological testing, and these may include ASOT, ANA, ANCA, anti-GBM. The renal physician can advise on these specific tests, so you don't need to worry too much about the serological testing. Other than that, then urine. So examination of the urine is an important component of the assessment of patients with acute renal failure. The findings of hematuria or proteinuria is important as these suggest glomerulonephritis. So doing a full ward test, looking for blood and protein, microscopy and cultures. So we're looking for, any red blood cell casts or any fragmented RBCs. We're also looking at the urinary electrolytes. This has been advocated historically. However, the measurement of urinary electrolytes and the calculation of their fractional excretions is really only of academic interest. The calculations are complex and the results are inconsistent, which in any case do not alter immediate management in the ED. So don't bother about them. Then in investigations, what we do is ECG, in particular, looking for signs of hyperkalemia. Plain radiology, so we're doing chest x-rays looking for any malignancies or an enlarged cardiac silhouette. This may indicate like a pericardial effusion. You can think about ultrasound, so like a fast ultrasound that can help rule out a significant pericardial effusion. Ultrasound of the renal tract is also a good screen to help rule out any obstructive cause. However, the examination is operator dependent and not always readily available, also like especially after hours. Then imaging, we can also look at CT scans. Like a non-contrast CT scan is particularly useful for helping to rule out an obstructive cause of acute renal impairment, particularly like in the setting of known abdominal or pelvic malignant disease. CT scans can also look for like the kidney size and indicate any other possible pathologies like tumors. Other than this, MRI scans are another option, but the gadolinium should be avoided in patients who have renal impairment, especially like acute renal impairment, due to the risk of developing potentially serious nephrogenic systemic fibrosis. Under investigations, we also have renal biopsy. So a formal diagnosis by renal biopsy is required in selected cases only for the detection of intrinsic renal diseases. The commonest indication will be a rapidly worsening kidney function with nephritic features. So either hematuria or red cell casts seen on urine microscopy. Okay, so moving on and looking at management, the initial management priorities in the emergency department will include like correction of immediately life-threatening complications or correction of the underlying cause where, we know the cause and where possible, deciding on the need for renal replacement therapy. The treatment steps will include number one, always ABC. So pay attention to any immediate ABC issues. Ventilation support may be required for a depressed conscious state. We may need like oxygenation, like CPAP may be required. We also need to address like any fluid overload, so like pulmonary edema. Patient may need furosemide or dialysis will be like the definitive treatment. If there's a cardiac tamponade, they will require urgent pericardial drainage. Making sure the treatment also involves like establishing continuous monitoring. The type of monitoring necessary will depend on the clinical setting, how unwell the patient is, and what is the likely underlying cause. So we can think about monitoring with ECG for hyperkalemia. We can think of monitoring with an IDC. This is not necessarily routine in patients who are voiding normally and are not unwell. It should be inserted for patients with oliguria or suspected anuria, or to monitor urine output. We can think of an IDC insertion in an unwell, shocked, or septic patient, or unblocking a bladder neck obstruction. An arterial line is not routinely necessary unless the patient is persistently hypotensive or particularly unwell. Note that there's no indication for routine CVC in cases of acute renal impairment. The only indication for these lines are when vascular access cannot be attained otherwise, or for the delivery of inotropes in the longer term. Moving on in management, we need to look at fluid resuscitation. So fluid resuscitation will be the prime concern in cases of pre-renal failure. The commonest causes will be hypovolemia and sepsis. So usual practice is to commence with 250 to 500 mils of fluid and then reassess. Note that cardiac tamponade should be considered also in cases of hypotension. Under management, we also need to consider managing electrolyte disturbances. So think about hyperkalemia. Hyperkalemia can kill quickly and without clinical warnings. See the separate video that I've done on hyperkalemia. It's also important to think about all the other electrolyte disturbances, especially with hypernatremia or hyponatremia or hypocalcemia. Look at the others and see, whether there's any acidosis, because if it is severe, this will require dialysis. The other thing to look out for in management is hypertension. An elevated blood pressure of more than 180 over 120 in the presence of acute kidney impairment is a hypertensive urgency. So treatment options include like a GTN patch or nifedipine. So managing the blood pressure becomes very, very important. Next in management, we think about if a relief of urinary tract obstruction is required. So bladder outlet obstruction can be usually managed by the insertion of an IDC, and ureteric obstruction is usually managed by the insertion of a nephrostomy tube. Other than this, we look at drugs. So making sure, drug rationalization is done. So consider, adjusting drug doses that are renally excreted. Avoid or minimize the use of known nephrotoxic agents, in particular like ACE inhibitors or potassium sparing diuretics or NSAIDs or any radiological contrast media. Drugs that need to be altered or reduced can be, like the metformin or diuretics or low molecular weight heparin. And then finally comes renal replacement therapy. So the need for urgent renal replacement therapy will depend on the acuity of onset of the renal impairment or failure, the patient's symptoms, the degree of response to other corrective measures, and the cause of the condition, overall condition of the patient or comorbidities of the patient. In general terms, renal replacement therapy like dialysis is considered for the following like clinical parameters. So if there's like a volume overload with acute pulmonary edema, or there's no response to diuretics, there's like severe uremic symptoms, for example encephalopathy, pericarditis, pericardial effusion, or if the patient has a poor urine output of less than 200 mils output in 12 hours. Other than this, we look at biochemical parameters. Dialysis can be considered for progressive deterioration of biochemical parameters, especially in acute situation, including uremia, a high serum creatinine, metabolic acidosis, or hyperkalemia. Okay, so ongoing monitoring for the patient will include like reassessing the patient clinically on a regular basis and to ensure that they've got regular observations. We will continue to monitor urine output and also continuing to monitor the fluid balance charts and considering, whether the catheterization of the patient is needed. We also need to make sure like we continue regular blood tests to check the kidney function, and are also required to monitor the progression of the serum creatinine. Any patient with an obstructive cause should be discussed urgently with the urology unit. Patients who may require urgent dialysis should be discussed with renal unit or ICU early. Any patient where the cause is uncertain should be discussed with the renal unit or ICU early. That's about it, guys, for acute renal impairment. If you're happy with this video, please hit the subscribe button and give this video a thumbs up. Please don't forget to share the content with your friends and colleagues. Until next time, look after yourself. Thank you.